We work with several hospitals to take care of their neonates, preterms, to take care of their complex pediatric cases, adults, pediatric cardiology, pediatric endocrinology, pediatric surgery. Today, Dr. Kefas will be talking to us about a few things, and Dr. Peter will also be sharing with us some of our experience in neonatology. We know that you will likely very much enjoy and appreciate it. So stay tuned, and I don't want to say enjoy the show, but there is a show more or less. After this, however, at the end of the meeting, if you're a doctor and you require CMEs, what will happen is that you will have gotten a link in an email for questions to answer. So I want you to pay attention so that you'll be able to answer the question. The questions are not hard, but they are only designed to make sure that people participate and pay full attention to it. So right now, I'll hand over to I'll hand over to Dr. Kefas to go ahead with his presentation. Dr. Kefas, over to you. Dr. Kefas, over to you. Hello, am I the one that is frozen?
Yes.
I'm not hearing anybody. Is anybody hearing Dr. Kefas?
Hello, good evening. Am I audible?
You are breaking. You are breaking up. This morning we're talking about, this afternoon rather, we're talking about respiratory distress. Yes. Dr. Kefas, you are coming in. Yes, good evening. Good. That's better.
Good. Good evening, colleagues.
Sorry about that, some connection problems. Dr. Peter. Yes, you are audible, but you are breaking up seriously. I think your internet connection is not strong enough. Dr. Peter, can you assist, please? Okay. So that we can get ahead with the presentation.
So you are audible. When you started,
Good evening. Am I audible enough? Good evening.
Yeah, he wants to, but he's
Okay, I can hear you. Go ahead.
Okay. Greetings, colleagues. Today we shall be considering respiratory distress in neonates as part of the continuation of our weekly webinar program. These are my names, Dr. Kefas, AG. Also later, Dr. Peter will be giving us some more information about some of the work we've started in this facility. These are the outlines of the program. We'll take some introduction, then we'll look briefly at the development of respiratory system in neonates, then we'll look at fetal circulation, and how these children transit from intrauterine to extrauterine life. Then we look at signs of respiratory distress and causes of respiratory distress. And also we look at the general management of respiratory distress. General, then later on we look at specific. Then later we'll look briefly on criteria for selecting types of respiratory support to give the children, which this is not specifically detailed for detail of respiratory support, but at least we need to have some idea what kind of respiratory support you need to give the children at what particular time. So then we look at conclusion. Respiratory distress is defined as presence of one or more of the following signs and symptoms, irrespective of the etiology. So we'll talk about tachypnea. Of course, we know tachypnea is respiratory rate more than 60, and grunting, or stridor, or wheezing, or nasal flaring, or chest obstructions, or cyanosis. The newborn infants are prone to a host of respiratory problems, and some studies have shown that about 20 to 50% of newborns in developing countries develop respiratory distress at one point or the other. It will vary from a mild, moderate to severe. In developed countries, the incidence is lower, like 7%. Of course, we need to know that prompt recognition and appropriate management is very essential to improve outcomes. And talking about appropriate management, we are referring to doing the right thing and not injuring the child, not causing some adverse problem to the child in the process of helping this child. Embryonically, we look briefly at the first 5 weeks of life, the formation of the proximal airways, and after that is followed by the pseudoglandular stage between 5 to 16 weeks, in which there is formation of the conducting airways. Then the canalicular stage between 16 and 24 weeks, formation of the SNI. Then the circular stage between 24 and 36 weeks, which is development of the exchange units of respiration. Then following that, from 36 weeks to 10, expansion of the surface area. And this is also important to talk about the surfactant, which is one of the problems we're going to look into later as the deficiency of surfactant in children in respiratory distress syndrome. So between 20 and 24 weeks of pregnancy, terminal sacs are lined by type 1 pneumocytes and also type 2 pneumocytes that secretes phospholipids called surfactant. Surfactant production begins at that stage and increases during the pregnancy to the age of around 34 weeks, when we start having the maximum amount of surfactant in the lungs of the babies. Let's briefly look at what the child passes through when the child is inside the womb. During pregnancy, the circulation, as we know, is parallel, while at the extrauterine life, we'll now be talking of a serial form of circulation. So one of the major focus we need to look at is the shunts in which the oxygenated blood tend to cross and help these children. But when you look at the ductus venosus, is one that bypasses the liver, the oxygenated blood from the placenta going to the intravena cava, and it crosses the bypasses the liver, and while in the right atrium, the foramen ovale is the one that conducts blood, the oxygenated blood, across to the left part of the heart. And also, you remember that ductal arteriosus is one of the focus where the blood from the pulmonary artery, blood from the pulmonary artery diverted to the aorta so that it can supply the lower part of the body. That means in the aorta is the oxygenated blood, then descending aorta to the abdominal aorta to the common iliac artery, umbilical arteries, then placenta, then back for the blood to be oxygenated again. During the transition from intrauterine to extrauterine life, the first breath that the child will give is actually supposed to open the lungs, and also in the process, the liquid-filled lungs is now changed to air-filled. However, later on we'll look at some of the challenges that may occur, like in transient tachypnea of the newborn, some of the mechanisms in which those one may be affected. There are also the placenta blood flow is terminated. Is one of the things that eventually can also lead to the increase in the peripheral resistance. At that particular time, so the resistance in the lungs is now reduced, while the one in peripheral circulation is now increased. And that also now, in a way, now forces the fetal shunt to close physiologically and later on anatomically. So what are the signs and symptoms one will notice as to be represented as things like that, as to be seen as signs of respiratory distress? There are several, but let's look at a few. But first one is tachypnea, and also retractions, nasal flaring, grunting, cyanosis, apnea, stridor, irregular breathing, head bobbing, and also tachycardia could be. Others could include other form of noisy breathing like stridors, and several other ones like snorting, especially when the upper respiratory tract, like the nasal, the nose is blocked by secretion. If you consider the causes of neonatal respiratory distress, there are severally, because anything from the airway up from the mouth, from the nose, down to the lungs, and also the structures around the lungs, like the pleura and the rest. Then from there, you can even go beyond to other systemic problems that can cause respiratory distress for these children. So let's just look at a few. Respiratory distress, when you see tachypnea, restriction or grunting or other features, you have to look at, is the child a preterm or is it a term child? And if it's a preterm baby, then you look at, is it occurring in the first 6 hours or is it later after 6 hours? So in the first 6 hours, you should be thinking of highly membrane disease, that respiratory distress syndrome. Then you should be thinking of features, maybe pneumonia, because in case if the mother had like premature rupture of membrane, which are some of the things that causes premature deliveries, then pneumonia can occur. And also some lung abnormalities. Are there some maybe hypoplasia or maybe cystic formation or several other things that can affect the lungs, that can give us abnormality of the lungs? And also shock actually can present at any stage in this, can be early, can be late, and can be in term or even late term or even term early or late in term children. So if it's occurring late, it can be pneumonia too, it could be congenital heart disease, okay? And also it could be hemorrhage, and hemorrhage could resolve spontaneously or could resolve from some of the therapies that we give can cause pulmonary hemorrhage, especially like maybe surfactant therapy. One could have pulmonary hemorrhage as one of the complications. Then in term babies, if it occurs within the first 6 hours, then you should be looking at transient tachypnea of newborn, meconium aspiration, persistent pulmonary hypertension of the newborn, asphyxia, can be shock, as I said, and lung abnormalities too could occur, and some air leak syndrome that could result from some of these problems, like meconium aspiration. One of the complications is air leak syndrome. And if it's occurring late, we're talking of pneumonia, polycythemia, or even anemia, congenital heart disease. Because some of the congenital heart disease could occur early and some could occur late. Looking more deeper into different regions in the airway of the child, when you talk about the nasal cavity, things like coronary atresia, nasal edema, and blockage with secretion can cause respiratory distress. In the oral cavity, when you look at things like microglossia, okay, micronatia, like Impia-Robin syndrome, and several other things that will affect the normal opening and also the tongue. Then laryngeal obstruction could occur from laryngeal webs, subglottic stenosis, or laryngomalacia. And in the neck, you have some obstruction that is compressing on the airways, like cystic hygroma, congenital goiter. Okay, and the trachea, you could have tracheomalacia, tracheoesophageal fistula, tracheal stenosis. They could all be things that could cause respiratory distress. And when you look around the lungs, the pulmonary causes, talk of aspiration syndromes, which Meconium aspiration syndrome is one of it, respiratory distress syndrome, then transient tachypnea of newborn, pneumonia, persistent pulmonary hypertension of newborn, pleural effusion, pulmonary hemorrhage, then the Ehrlich syndrome, said that could result from some of the complications, then lung hypoplasia and agenesis. And there are some other extra pulmonary causes, as I said earlier on, hyperataxia, congenital heart disease, metabolic acidosis, which will result from any cause, polycythemia, anemia, shock, seizures, and sepsis will be also known. They are also known causes of respiratory distress. So in managing the children, remember our ABCD. As a good clinician, you have to talk about the ABCD of resuscitation. You have to resuscitate the children. So we don't waste time just taking history, but first our eyes should be on the child so that we look at the airways. Is this child gasping? Or the child having stridor? That's a sign of respiratory tract, the airway obstruction. So, and what can we do? Things like ABCD of resuscitation should start without delay. Then insufficient breathing like apnea or poor respiratory effort, we need to look at that and what can we do in that regard. Then circulatory collapse. The child bradycardic, hypotensive. I remember several hospitals lack the capacity to measure blood pressure for these children, even for bigger children, talk less of neonates. It's very, very important. We need to check the blood pressure. The child hypotensive, remember we talk about shock of recent. Then poor perfusion, we talk about capillary field. Then cyanosis. Of course, we know cyanosis, we talk of central and peripheral. However, remember the first 48 hours of life, you may have some peripheral cyanosis that are really not pathological, like talk about acrocyanosis. There are some of these scores like the Down score and also Silberman-Anderson score. There are scores in which you can use to assess the severity of the respiratory distress in the children. Okay, the scores, I try to remember from the severe forms, that's the extreme forms, this is the highest score, from 0 to 1 to 2. But I look at it from here, like if the cyanosis is much, like the FiO2, the child is cyanosis when the child is on oxygen with FiO2 of 40 or more, that shows that it's severe, so we can give a score of 2, then lower one in the room air and also none in that order. Something with retractions, if it's severe or mild, and also when you talk about grunting, can you hear the grunt without stethoscope, or you hear only with stethoscope? So that characterizes the severity. But the most important thing is we need to be doing it every 30 minutes in order to monitor the progression. Are you winning with your intervention, or your intervention is failing? So based on that, it need to be measured serially, and also advise that this can be printed and maybe pasted in the neonatal unit so that one can always access it. You may not need to cram it, but at least you can always access it and use it to assess the children. Same thing goes with Anderson retractions. This one is commonly used for the preterms, but the other one I mentioned earlier on can be used for both preterm and also the term babies. Can always benefit them. So we talk about the severe forms, like the score of 2 in the upper chest. I'm talking of seesaw. That means as the inspiration is going on, as the upper part of the chest is going down, the lower chest wall is going up. That's what we call seesaw. Then we talk about the lower chest. Is it marked or just visible? Same thing for the diaphragm, and also something with nasal dilation, that's the freedom of earlier nasal. Something we can look at, if the score is greater than 6, then you are looking at imminent respiratory failure, as we noticed in the first one. So apart from the immediate resuscitation, we talk about, remember as we told the immediate resuscitation, we're talking about, is it a newborn baby or maybe it's a child that has been brought to you, but most of the time we are considering the newborn babies in this particular time. But first, you need to talk about the history is very important. So you find out the history. Is this a preterm delivery? Is this what transpired before then? Was there prolonged labor? Was there meconium stain, liquor? So all those history, and also was there oligoamnios or polyhydramnios? They all point at something that will help you to make a valid diagnosis so that appropriate treatment can be given. Then physical examination. You have to do a thorough physical examination this time around. Apart from the chest, you have to examine all other systems. Of course, the cardiovascular system, as we said earlier on, very important because it's closest to the respiratory system. Then chest X-ray is one of the investigations that's very important in order to assess what is happening in the chest. Of course, we know the technicalities and difficulties to do X-ray for the tiny babies, especially when you're battling with respiratory support. But of course, thank God for the advent of mobile X-rays, in which I believe several centers should be able to acquire that, so that at least you can also, the child is inside the incubator, you can come and do an X-ray so that you have an idea what you're dealing with. And we do PCV, complete blood count, sepsis workup, depends on the condition you're dealing with. Of course, monitoring blood sugar is very important, because one thing we're talking about is how to do supportive care, so that you don't concentrate on respiratory distress, and also you don't allow other things to be going wrong. Hypoglycemia, with sepsis, or electrolyte imbalance, and several other things. Shock will come and set in, and also several other conditions. So managing the supportive care is very important, and also importantly, also the nursing care. Okay. Of course, when we talk about anticipatory, very important. You don't wait. Management of neonates, you have to go ahead of them. So before the delivery of this child, what are you anticipating? What are the risk factors? What are the things that you think is going to give you a problem about this child? So that you check your capacity and know. Is this something that you need to refer intrauterine? That is, to refer the mother to go and deliver in a center where it will be easier? Or you have the capacity and how to transfer the child in a way that it will not cause more harm. So anticipation is very important, and also putting this counseling is very important. The parents, apart from the anxiety and also the financial implication and everything about managing the child, they need to be carried along. So right from the beginning, the parents need to be educated on what is happening. So that is why even before delivery, the neonatal team is supposed to, if the opportunity exists, if it's something very urgent. If it's not very urgent, it's important we try to talk to the parents what we're expecting, okay, the possibilities, because at least from the history and from the ultrasonographic findings and things and the GA and everything, you already know what you're anticipating. So it's very important. Then neonatal resuscitation, if they call you and the child is already now out, or maybe of course you are prepared and the child is delivered in your center, for neonatal resuscitation, which is one of the major topics we normally take during our annual symposium, pediatric symposium, which we normally do yearly. So one of the things is a full course. So one of the periods during our symposium is one of the things that we do. Of course, neonatal resuscitation is a step that you need to take in order to stabilize the child and also to do the right thing. So depends on what we're expecting. So every person that's attending to delivery, of course, is known as that person should have knowledge of neonatal resuscitation. Being a nurse, being a doctor is very important. And that's why even the obstetricians, at least they normally during their training also they do training in neonatology. So it's very important how to keep the children alive, so that the first 1 minute is very important for this child. It can mar the child or it can bring success. And remember, talk about medical legal pitfalls are also things that are rising in our society. Also, you need to improve the oxygen delivery to the lungs of the children. So let's talk about some of the various respiratory support that can be given to the children. Supplemental oxygen, the CPAP, or mechanical ventilation, or ECMO, or surfactant therapy, and also improve blood flow. Remember, we talk about checking the blood pressure, okay, checking the PCV, so that you need to give volume expanders, you need to give blood transfusion, and several other things. You need to even do partial exchange. Those are all things that need to be done in order to give the child adequate supportive care. Then arterial blood gases, we need to check that, especially in severe respiratory distress, because that score will also give us, like score greater than 3 will suggest ventilatory support requirement. So it's supposed to help us to know where and where to change. So we need to monitor it serially. Okay, in our center, the Cardiocare is there, the machine is there, and also it's something portable that can be used in any of the centers. So there are things that are available, and every hospital that have NICU should have that. So you need to minimize oxygen consumption. Of course, you need to talk about thermoneural environment for this child. And also, severally, sometimes we see the oxygen that will be delivered to the children. They will be cold on our own. So we need to humidify it, and also we can warm it, because from inhaled oxygen, when it's cold, it can also affect the temperature of the children, especially when you talk about these preterms, all of them actually, but the worst in the preterms. Depends on the respiratory distress. You may withhold feeding for the meantime, or you may feed, depends. So, but most of the time, you may need to withhold so that you stabilize the child. After you put UVC or intravenous line and give minimal handling, because whether we are talking of preterm or not, but we tend to look more to preterms, this minimal handling, because of the fear of IVH. It's very important. I also need to know also that, like some children with Meconium aspiration syndrome, agitation can also increase the risk of them having pulmonary hypertension. So minimal handling is not just for premature, but for all children. Then good nursing care, okay, so that you need to monitor closely the vital signs of the child, and also check the oxygen therapy you are giving. Is it really going? You need to check the airways and the rest. Then what are supportive care, as we said earlier on, like the nutrition, okay? The nutrition, and also we need to give adequate support to take care to watch out for things like infections, and also if there are congenital heart diseases, so that we can also address it, and other surgical causes, as we said earlier on. Then consult and referrals, as we said, is very. So the ENT could be involved, and different other, depends on the condition. So in transient tachypnea of newborn, let's look for that. One, occasionally some people call it the respiratory distress syndrome type 2, but of course, we all know it's a mild and self-limiting condition, and usually we see it in term babies, okay? Also some children that deliver via CS, whether emergency or elective CS, because that process of passing through labor, you know that towards time, the mechanism of the fluid secretion into the lungs is reversed because of glucocorticoids and also catecholamines, okay? All those, they increase so that to help in resorption of fluids from the lungs. the important features you have to notice in them is they recover very fast. For some of the experiences we see, the child will be having tachypnea, respiratory distress, but by the time you start intervention, before you know it, in less than 6 hours, you start seeing dramatic improvement. So very important for us to okay, it's very important for us to watch out for that. And of course, as you said, it's actually a diagnosis of exclusion, so you need to look out for other things, other strong differentials. So the pathogenesis, as I've already said earlier on. So what are the clinical manifestations? Is the respiratory rate. The child will be tachypnic and also have some mild retractions, may have cyanosis. Okay, but most of the time they need oxygen that is less than 40%. So with that, they'll be able to do well. They hardly require intervention like a mechanical ventilation. Then the grunting, then also they recover early, some within 24 hours and some within 3 days. The lungs are generally clear when you listen to the chest, but sometimes you can hear some transmitter sound. In the chest X-ray, you see, okay, like some fissures are filled with fluids. Then there's some kind of over-aeration and also the flattening of the diaphragm. So occasionally you may see pleural fluid. This is the X-ray of the child with TTN. So generally, treatment is supportive with oxygen and CPAP and intravenous fluid ventilation may not really be required in terms of mechanical ventilation. They can normally do, most of the time they do well without oxygen or maybe with supplemental oxygen or maybe with CPAP. Okay? The respiratory distress syndrome, which the old name highly membrane disease, is common in premature infants. The incidence is inversely proportional to the GA of the children, as we can see, less than 28 weeks or 32 to 36 weeks and so on. So, but it's rare in term babies. So what are the things that increase the risk of child having respiratory distress syndrome? Infant or diabetic mothers, of course, the premature, multiple pregnancies, and especially the second child, okay, the second baby, transsection deliveries, precipitous labor, asphyxia, cold stress, and also history of affected infants in the family. That means there could be some genetic factor related to that. But of course, the following have reduced risks, maybe like chronic or pregnancy-associated hypertension, maternal opiate addiction. Of course, it has its own negative sides, of course, but in this particular scenario, it's tend to protect the children. The prolonged rupture of membrane, and antenatal steroid use, which is very important. So studies have confirmed that. Surfactant deficiency leads to production. I mean, there's the decreased production of this, of course, as I mentioned earlier on, depends on the gestational age. The younger the child, the lower will be the volume of the amount of surfactant in the lungs of the children. Okay, so as we said earlier on, when this happens, of course, the function of this surfactant is to reduce surface tension and prevent the alveolar from collapsing. So when these are absent, then alveolar collapse is now imminent, okay? And highly membrane formation, which are some proteinous substances that are produced as a result of the inflammation, then can give rise to interstitial edema and make the lungs more and less compliant. So greater pressure is actually required in order to expand the alveolar at that particular time, which that's why most of the time we start with the CPAP because it has that function of extending the alveolar. Decreased lung compliance actually occurs because as a result of that, then the combination of these problems like hypercapnia, hypoxia, and acidosis, that also give rise to pulmonary arterial vasoconstriction, and that leads to also increase in right to left shunts, which is supposed to have reversed when the child is born. Okay, like through some of those foramen that we talk about, the foramen orale, the ductus arteriosus. Then pulmonary blood flow also is reduced, ischemia, and also you can have capillary endothelium and alveolar epithelium. There's ischemia to that, and also leakage of plasma. That is what leads to the production and the proteinous substance that is deposited that's gotten some of the old names as Limi membrane disease. Okay. They present with respiratory distress, as we said, the tachypnea, intercostal and retractions is very important. Remember, we talk about the Silverman-Anderson scoring. You can use that in order to assess child grunting, cyanosis, progressive worsening of this cyanosis occurs, and the breath sounds are harsh and tubular in quality, okay, with fine ribs. The severity of this condition peaks at about 24 to 48 hours. That is why, from the beginning, you don't underrate what you are seeing, so that the child will need very close monitoring. However, in some, you can experience, most of them, you can experience resolution by 3 to 4 days without even surfactant therapy. But if surfactant is available, and also you know that the child qualifies, because we are supposed to have individual or that's regional or individual facility criteria for which one is supposed to have, so that you can know when to start, when to give surfactant, and whether you should give as a prophylactic or whether you should give a rescue, depends on how the protocol goes. Of course, close monitoring of the children so that you know when to give, so that in case you know when you need to give and you don't give, you know, that's where problems arise. So the child with develop apnea, irregular respiration may set in, and also respiratory failure. Of course, we talk about acidosis, both metabolic and respiratory acidosis can result as a result of the hypoxemia. The death is rare as a result within the first day. However, within the second to 7th day, it can happen. So that brings us to the need for continuing care of these children and continue being vigilant. Then, of course, they die as a result of respiratory failure, okay? And they have other complications that will arise, like the emphysema, pneumothorax, okay, pulmonary hemorrhage, and IVH, and some of the problems that will occur. That could be other comorbidities that can kill the baby. These are some of the X-rays. One of the popular ones that we know is the whiteout, okay, the whiteout lungs, okay, the one in this grade 4, the one on the right, this, okay, completely white out. Another thing we need to see again is we need to appreciate, okay, this, okay, we need to appreciate that, because some of the things that we see in the X-ray of the children, of course, we see that. Of course, differential diagnosis like early onset pneumonia from GBS. There are some studies that shows that it's not common in our environment. Then we have pneumonia. That's the pneumonia that will occur as a result of any other organism. And some cyanotic congenital heart diseases can present with early signs of respiratory distress. Then persistent pulmonary hypertension of newborn, then transient tachypnea. They are all things, some of the risk factors we see that they actually share some risk factors like this TTN. You talk about CS, you talk about CS babies and infant of diabetic mothers. They share some of those risk factors. Okay, then spontaneous pneumothorax, pleural effusion, diaphragmatic hernia, or lobar emphysema. Of course, we talk about supportive care. Treating the children, you need to take care of of course, make sure the child is not hypothermic. So you keep the child in a thermonuclear environment, and the IV calories, very important, supportive care, and humidifying the air, then CPAP prevents collapse of the alveolar, then assisted ventilation can occur, as we said earlier on. Talk about the criteria. And other ventilators, high frequency ventilators, there, jet ventilators. Okay. Surfactant therapy. It can be given actually in multi-dose, but sometimes only one dose is enough for some children, but at least we should aim at 4. As I said earlier on, it will depend on the protocol. Okay, so if I'm giving a prophylaxis, if I'm giving a rescue, okay, so those can be repeated within 6 to 12 hours. When you give within the first 2 hours, that is the early rescue, within the first 6 hours, within the first 2 hours, then you need to repeat within 6 to 12 hours if the need arises. Okay, but appropriate monitoring and monitoring equipment must also be available, like radiography, because you need to check X-ray to confirm what is happening, because in case other complications like pneumothorax are setting in or other things, so you need X-ray in order to confirm that. Then blood gas laboratory, as we said earlier on, the pulse oximeter is very important. Complications that could arise like air leak syndromes, okay, you should consider that when maybe the child is suddenly doing well, then suddenly you see the child's condition deteriorates, okay, you should start considering some of those complications which may arise from the disease process or as a result of the intervention one is given. So it's more common in babies who are receiving mechanical ventilation. So that's why there's need for adequate training and also adequate monitoring when the child is on that, both the part of the doctors and the nurses. Then, of course, the therapy, okay, if it's mild, you may just watch, but the oxygen, 100% oxygen need to also be avoided, okay? So we're talking about when you have pneumothorax, if it's mild, you don't need to intervene, okay? But you need to increase the concentration of oxygen, though you need to monitor, because there's supposed to be an ideal SpO2 of the children. If you're recording SpO2 of 100 in the children, then you know that you may be doing harm. So the ideal SpO2 is supposed to be, there's a chart for that, so that for a preterm baby between 88 and 92, and for a term baby maybe it can go up to 95. But recording oxygen saturation of 100% is actually not beneficial to the children. It may actually be risky. So it's something that we need to watch out for as we manage the children. As I believe there are other health personnel that will monitor the children, so it's very important. Then other complications like intracranial hemorrhage, okay, all can happen. Then also in prevention, you need to look at how do you prevent prematurity. It's actually a difficult thing to do, but as much as we can, if we can prevent, actually the prevention varies from different stages. Even prevention of cervical incompetence, okay, prevention of cervical incompetence, so that the children will not, so that the woman cannot have cervical incompetence. So general education of the community about it, maybe indiscriminate abortions, or maybe things that can cause those, and infection control, okay. And in the days of IVF these days, there are some multiple gestations that may actually, because they increase also the risk of premature birth, okay. So care need to be given in that direction. So betamethasone or dexamethasone are part of the things that they are studied, and also they are actually confirmed that yes, they are very, very important. Then you may check the lecithin hemoglobin ratio in the amniotic fluid, okay. If the value is like more than 2, then at least showing at least the lungs is matured and the child can be delivered at that particular time. So that's the importance of doing that. So remember we talk about first dose of surfactant into the tracheal, okay, into a symptomatic baby, okay. It can happen immediately after birth, that's prophylactic. Then it can occur within the first few hours, maybe like 2 hours, that's early rescue. Maybe we'll rush through meconium aspiration syndrome. Meconium stain amniotic fluid is found in about 10 to 25% of pregnancies, or close to during the delivery. However, only about 5 to 10% of them actually develop the problem. Okay, 30% of them also require even a more advanced way of mechanical that's advanced respiratory support. So mortality can be as high as 3 to 5% in advanced countries, maybe more in our setting. So what are the risk factors? We talk about post-term, preeclampsia, maternal hypertension, diabetes, abnormal fetal heart rate or IUGR or oligoarrhythmia. Okay. The mechanism, as we said earlier on, one of the things that normally trigger the production, the passing of meconium into the amniotic fluid is usually hypoxia. But however, there are some studies that show that even physiologically, okay, some children neonates some fetus can pass the meconium within intrauterine without any form of hypoxia or any form of stress. So, of course, we know that one leads to induced parasympathetic stimulation and causes the anal sphincter to relax. So, I don't know whether this diagram is clear, but as the meconium is aspirated, that's the major thing, then what happens? They can cause obstructive, okay, symptoms like the airways. So we talk about upper airway obstruction, we talk about acute hypoxia. This can all lead to some of these features like hypoxia and so on. And also when you talk about diffuse particles, that is tiny particles, can be incomplete or the bulbar obstruction and can easily lead to this air leak syndrome like pneumothorax and the rest. And can also cause complete blockage, which can cause atelectasis. Then form of inflammation, irritation in the lungs. You can have interleukin, cytokine release like interleukin, tumor necrosis factor. They are all cytokines that can be released, and all of them eventually can give rise to the pathology. Okay. The clinical manifestation either the tachypnea, the retractions, the grunting, cyanosis. Of course, we should also watch out for some of those complications like the air leak syndromes, okay? The pneumothorax, they are one of the complications that will occur because we know that it can take any of the direction and can be multiple problems. So, and if it's persisting for days, that's when you should talk about sometimes it may even be the PPHN. However, it's also important for us to know that actually mechanical aspiration syndrome can actually last for several days. So it's very important if maybe you do some investigations like in our center, quickly, if it's persistent, we quickly try to do echo for these children so that we can rule out PPHN for these children. So that if you rule out that, if it's just that, maybe just the persistence of the symptoms. I've seen one that have lasted for almost 2 to 3 weeks. I've seen that before in the course of my practice. So it's possible for the symptoms to last like that. So these are some of the x-rays. You can see the infiltrate that is here, and also this looking like some form of pneumothorax. But you can see, obviously, you can see a pneumothorax here. This is air collection. Of course, we said they are term babies. Most of their term or post-term. Of course, meconium staining, you need to watch out for that. Sometimes, if it's in time, if the room is dark or maybe in the night, sometimes it can be difficult to see. But information from the obstetricians can give us that clue that yes, there's likelihood that is meconium aspiration syndrome. And of course, if the child is not born in your place, sometimes the information may be lacking, but proper examination of the children, you see, look at the cord, the nails, the skin, and also the onset of these symptoms occur within the first 4 to 6 hours. And also you see, look at the chest, maybe barrel shaped chest. They are all things that you should watch out for. So we still believe that neonatal resuscitation, when the child is born, when the mother has an amniotic fluid stain like as of 2015, it's now been known that some of those practices in the past, some studies were really done and proving that they didn't really show much difference. I remember in those days, the major teaching were, of course, when the head is born, you have to suction the nostrils. Also, when the child comes, when the child is not active or is not vigorous, you must intubate and look and check down. But it's now known that as of 2015, the neonatal resuscitation program has found out, and also they've done studies both in developed and in developing countries, and it's found now that there's no need for that. The normal process of neonatal resuscitation, of course, there's a place for intubation if need be along the line when you're resuscitating a child, but it shouldn't be different from for children that are born with a inside meconium and stain-like than without. Okay. Then the respiratory support, as we know, from oxygen can go to mechanical ventilation, or you can go even ECMO, and they may have surfactant therapy because it's believed that meconium can displace and inactivate the surfactant that is being produced. So it's one of the things that could happen. And supportive care, very important, and also to watch out for these complications and manage them appropriately. So the outcomes, one of the major things about the outcome is the asphyxia that normally go along with it, because with the hypoxemia, child can have features that may potentially lead to like seizures, maybe cerebral palsy or mental retardation. The symptomatic cough may persist because of that irritation. Some of the children may continue to have chest problems, maybe things that may look like maybe like asthma. So all those ones, there are some of the things that will follow. So taking neonatal, birth history is very important. It may be some of the things that will be giving some children that kind of symptoms. So for PPHN, can be primary, can be secondary, as we see. Then investigation, as we see, we can do echo, is very important, as we said, so that you know the pulmonary pressure. And management is the same like the PPA, the same, but one of the things that we need to do is high flow oxygen, nitric oxide, sildenafil. There are some of the management protocols that we need to give the children. Nitric oxide has been studied and is very effective. So treat also underlying cause, either medical or surgical, and counseling is very important. For pneumonia, it will occur early and it will occur late. It could be community acquired. Okay. Then let's talk briefly about maybe anticipation. We've talked about it before. Then planning the delivery of the children and also planning transferring the children. Okay, could be early or intermittent referral, if need be, fine. You need to do that so that in order to get the best of the outcome. Remember, also when you start managing the children and if the respiratory distress is worsening, you start thinking of some of the complications that will arise from that. Surgical courses, including like ENT or surgical cases, you need to refer them or within the same hospital or outside the hospital. If you have the surgical team within an ENT, of course, invite them to have it jointly intervene in managing the children. So briefly, we just look at some few slides about indications for CPAP use. We just rush through it. Respiratory distress syndrome, transient tachypnea, newborn, post-intubation. When a child is on mechanical ventilator and you are weaning up, you put the child on CPAP. And apnea of prematurity, meconium aspiration syndrome, pneumonia, laryngomalacia. So, but criteria, we need to watch out for the child with spontaneous breathing. Okay, the hemodynamic stability, that's the issue of vital sign, the capillary fill, you need to check all those ones. Then also you have to know that there's no upper airway abnormalities for this child. Also the child is not in like respiratory failure. Remember we talk about scores that are impending respiratory failure. If you are having those kind of things, then you have to be careful. So contraindications, okay, for the CPAP, we also talk about the progressive respiratory failure, continuation like congenital malformation like congenital diaphragmatic hernia, okay, and TAF, coronary atresia, all those are their contraindications. The infant with severe cardiovascular instability, as we said earlier on, units with poor or unstable respiratory drive, okay. Then when do you say CPAP is failing as the child is on CPAP? When the child is on CPAP and you see continue to have apnea, that means CPAP is not helping the child. Of course, there's a proviso. We'll look into that very soon. And respiratory failure, we'll talk about these values, the air, the cerebral gases. And once you know that the FiO2 of the CPAP is, you know that you're getting above 60, and before the child will achieve a saturation, or it's not achieving saturation when you're getting to 60, then you know that there is a problem. You need to go higher. Then worsening respiratory distress and agitation, okay, not relieved by simple measures. That maybe the child is now restless, child is now maybe going into impairment. Those are features of respiratory failure when the child is now getting to that. Of course, we need to review that before you finally conclude that, okay, this CPAP is not helping the child. Are the prongs in the nose, okay, are these prongs in the right, are they the right size? The circuit, is it leaky? Okay, make sure that it's not leaky. And the nose has been cleared. Maybe there are secretions and you place baby prong and did not improve. Okay, is the mouth closed or open? Okay, the mouth is supposed to be closed. Okay, the neck slightly extended, you need to check that. And if you try also higher, maybe pressures, like almost 10, but you are still getting lower value, you're not getting response, then you know that yes, obviously CPAP is failing, and that will take us to indication for mechanical ventilation. And apnea, despite maybe you do PPV, that is I'm bagging for 30 minutes or more, then you know that yes, you need to move from there. 100 less than 50, not less than 100 per minute are not increasing due to resuscitation. Frequent or severe asthma and apnea and bradycardia. Okay, more than one apnea event in 24 hours. Also, measure that while the child on CPAP need to. Okay, heart rate of less than 60 per minute, shock. Okay, persistent max severe retractions, suspected airway obstruction despite adequate suspected airway obstruction generally despite adequate support that you are giving. Then the FiO2, as I said earlier on, of 0.06 like 60, okay, to maintain FiO2, then you know that each child will need a mechanical, will need to go advanced. Severe metabolic acidosis, okay, and also severe respiratory acidosis. So, in concluding, the immediate postnatal period of a child, actually, they are very crucial, okay, because of the process of adaptation to the extrauterine life. So that's why most of the things we learn in this presentation is to watch out for that first 24 hours, start from there before you move on. Very important for these children. So the newborn infant is vulnerable to a range of respiratory problems, all presenting with respiratory distress. Okay, and of course, also other things that can cause respiratory distress. So it's important that any health worker or any personnel that who come in contact with newborn infants is aware of signs of respiratory distress and should know what to do. Okay, so prompt and thorough clinical assessment and investigation is required for these neonates presenting respiratory distress to ensure accurate diagnosis and appropriate intervention, including neonatal resuscitation, which we said one of the integral part of our programs, and also we are always ready to assist and also provide with different other perspectives. Thank you for listening. Hello, Dr. Seko there? Hello? You want to use it?
Okay. Nice. You went off. Okay, hello, good afternoon all. I will continue the presentation here. I am Dr. Peter. So we'll be sharing some of our research findings from the Children's Hospital. So I will talk on the etiological profile and clinical predictors of mortality among units respiratory distress seen at the Limi Children's Hospital, Abuja, Nigeria. This is actually a preliminary report as the data collection is still ongoing. The aim of the study is to determine the etiologic profile and predictors of mortality among neonates with respiratory distress in our hospital. We aimed at looking at the etiology and to determine predictors of mortality in these babies. Well, the study is prospective, it's ongoing from August last year to July this year, anticipated to be completed in the next 2 months. We included all newborns seen in our neonatal intensive care unit with respiratory distress during this study time frame. We excluded all severe respiratory distress that culminated in death before a definitive diagnosis could be made, and also those who didn't have access to their mother's history. So we defined respiratory distress as presence of one or more of the following. This was said earlier in the presentation by my colleague. So at abnormal respiratory rate, which could be tachypnea, bradypnea, pulses in respiration, or apnea. So it's tachypneic if respiratory rate is more than 60 breaths per minute, and bradypnea when it is less than 30 breaths per minute. So when there are pulses with desaturation and associated cyanosis, we say apnea, or long enough, more than 20 seconds. So if the child has abnormal signs of labored breathing like respiratory grunting, nasal flaring, and as stated, we see labored breathing, so with or without cyanosis. Now, from our preliminary reports, we found out that unlike most of the developed countries, and probably difference in definition criteria, so we do not want to miss any baby at all with respiratory distress. So surprisingly, we found a prevalence of respiratory distress as high as 95.8%. This is really high, and as much as one pays attention to them, you pick them and then you have good outcomes. So male to female ratio was 1.2:1. Now, this is birth weight stratification. So those who were extremely low birth weight, less than 1,000 grams, were about 13%. So we actually have babies, we've managed babies commonly below 1 kg, and we have success among them. So the very low birth weight units, less than 1.5 kilogram, were about 21.7%. Low birth weight below 2.5 kg were 17.4%. Those who were normal weights, where they had a chunk of it. So respiratory distress is not only in, we found that it's not only in preterms, because those who had respiratory distress, in fact, more were even those who were normal weights. And surprisingly, we found 4.3% of macrosomic babies, although they were basically infants of diabetic mothers, and it ties up with the initial theory we had. Now, what were the modes of presentation? Those who had abnormal respiration, that was the commonest. So up to 43.5% had abnormal respiration. Labored breathing was present in up to 13.3% of them, whereas cyanosis was the least. However, some had a combination, and apart from respiratory, abnormal respiration, respiratory rate, the combination of the abnormalities were the commonest. Age of presentation, we realized that a larger number of them presented within the first 12 hours of life. And then surprisingly more even after 24. We had a good number still after 24 hours of life. So we just want to look at briefly the etiologic profile we found out in our study. Respiratory distress syndrome was realized to be the commonest cause of respiratory distress in our series, with 23 of our newborns out of the 46 that were studied over this time frame had respiratory distress. 7 had cardiac abnormalities. In the earlier presentation, respiratory distress could be pulmonary, non-pulmonary. Sorry, respiratory, non-respiratory. And the respiratory could be respiratory, pulmonary, respiratory, non-pulmonary. So cardiac causes are the non-respiratory causes. Now we found that 3 of them had persistent pulmonary hypertension of the newborn. And so how did we diagnose this? Well, commonly we could use bedside pulse oximetry. And so pre-ductal and post-ductal oxygen saturation difference of greater than 3% to raise the suspicion. Arterial blood gases also, but we used echo, which is diagnostic. And commonly, we find that the regurgitant velocity as a tricuspid valve was found to be quite high. So commonly, there is chamber dilatation of the right chambers of the heart. Now, if you understand the pathophysiology, you realize that the fetal lung is wet, non-functional, because in the womb, it is the placenta. And so persistent pulmonary hypertension, which was the old name was called persistent fetal circulation. So this child is not transiting to extrauterine life as early, as fast as we want. So the lungs, the pressure in the lungs were found to still be very high. Commonly, there will be a patent foramen ovale, an atrial septal defect, or a patent ductus arteriosus with them. We also found a child with a complex cyanotic congenital heart disease, has single atrium dysplastic tricuspid valve, severe pulmonary hypertension. So in this abnormality, single atrium with 2 ventricles, you say is quadriloculare biventriculare. That's the old name. So quadriloculare, that's 3-chambered heart with 2 ventricles, so 1 atrium. So we also found from echo 2 babies with large PDAs and a large ASD. Well, if you look at it from neonatal cardiology, you wouldn't expect an atrial septal defect to present with respiratory distress, but these were incidental findings, and is not present, is noteworthy to present, because we know that the change in pressure changes in the chambers of the heart should have normalized at about the 8 weeks of life and thereabout the shunting. After that, before shunting starts manifesting, but this manifested quite early and it is worth sharing. Transient tachypnea of the newborn was present in 7 of our neonates, whereas hypoxic ischemic encephalopathy, commonly these ones presented after 24 hours because all of them were referrals from, they were outborn. Now, Meconium aspiration present up to 4 of our neonates. Now, this is the last slide of our findings. So therapies, oxygen therapy is necessary in all of them. So we give CPAP in all of them. So 45.7 received surfactant therapy, minimally invasive surfactant therapy. So that's the new thing. We go minimal and then we instill, and we've had very good outcome. We've had very good results. So 45.7, up to 10.9% had to be placed on mechanical ventilators. Now, considering the array of our patients, including extremely low birth weight neonates, very low birth weight neonates, low birth weight and all that, we had a survival of 80.5%. Now, remember, the study is supposed to look at the prevalence and predictors of mortality. So since it's still ongoing, by the time we complete our 1-year data collection, we'll do Cox regression hazard models to determine baseline characteristics associated with those that died. So we'll use factors found that are significant with the Cox regression model to be significant predictors in the bivariate Cox regression hazard model will be entered into multivariate Cox regression model, and Kaplan-Meier survival analysis will be done for factors that remain significant at multivariate Cox regression model and expressed as logarithm rank test. So this is so far how we have gone. We found quite some good number having respiratory distress. And it's worth noting that if we look for respiratory distress, we realize that up to 95.8%, we take care of them, we will have good outcome. Thank you. Okay, so while we wait for the host to come up, we would like to address some questions. We would like to address some questions we already have in our inbox, but we would like to wait for the host, and we'll be happy to get more questions. We will be happy to get more questions from participants. No, he can come. Okay, he has not. Can you get my phone and the papers? Okay, hello. Dr. Kefas is back online. Dr. Kefas, please, can you unmute yourself? Dr. Sepu is not on. Dr. Sepu should have. Dr. Sepu should take it. Something else. Was I on?
Hello?
Okay.
Hello?
Yeah, hello. Hello, sir.
Yes, so how far? Yes, please go ahead.
Okay, so we are done with both presentations. So we are open to questions.
Okay, so there are questions in the Q&A box, so we'll start answering them. And anybody that has questions, please raise up your hand, and then we'll allow you to talk as well. So Dr. Peter, maybe you can go ahead with the questions from the Q&A box.
Okay, thank you. So for the first question, for blood pressure measurements in neonates, is a pediatric cough adequate, or is there a specific instrument? So there are specific measurements for cough sizes in pediatrics generally, and there is no single pediatric cough, because a pediatric cough that is adequate for a 2-year-old will not be adequate for a 7-year-old. So we are talking of a cough size that is appropriate for the neonate. So we have the cough, the bladder length of up to 80% surrounding the upper arm, and the width up to at least 40%. So there are neonatal coughs to round that up. There are neonatal coughs specific for them. So we remember also that when measurements are taken, the American Heart Association 5th percentile of blood pressure for them is actually 60 millimeters of mercury. Blood pressure in units will be taken through the palpatory method, just like we do for every other person. We can also use other methods like Doppler ultrasound or oscillometric method. So if facilities are available, those are options. But I think cough sizes for neonates for the palpatory method becomes one thing that should be commonly available. And we have those monitors in our facility, so they are possible to get. So that's for the first question. So, for the next question, why is the risk of respiratory distress syndrome higher in the second twin compared with the first twin? So why is the risk of respiratory distress? Because respiratory distress syndrome has its own definition, which is just one diagnosis of respiratory distress. So rather, it should be, why is the risk of respiratory distress higher in the second term? Well, the time interval between the delivery of the first and second twin makes the first one come out, and the second twin for vaginal delivery is exposed to more perinatal stress. So if the baby is not brought out, with every uterine contraction, there is reduction of blood flow to the baby, and the baby has more risk of asphyxia. And so higher compression, more contraction, more reduction in blood flow, they are at risk of perinatal asphyxia. And perinatal asphyxia is recognized as one of the non-respiratory causes of respiratory distress. So they are more prone to respiratory distress than the first twin that comes out first. So that's for the second question. So the next question, why is maternal hypertension a decreasing risk factor for respiratory distress syndrome? Maternal hypertension, a decreasing risk factor.
Yeah, this. Because of the constant the placental insufficiency is one of the things. So the child is exposed to weeks of stress, and that helps to speed up in a way the production of the surfactant as a result of stress. If a preterm needs blood transfusion and is hypothermic, can the child be transfused even if the blood isn't warm enough? No, we're trying to preserve calories, so it's not wise. It's good to warm it a bit, few minutes. I don't think it will make much difference. Okay. It is added advantage. Okay. Question from I think Dr. Nicole. Thank you. The anti-inflammatory role of caffeine is added advantage in increasing success of CPAP and reducing ventilator-induced lungs injury has been postulated and documented. What is your opinion on this experience in our practice? Well, we give caffeine to children for prevention of apnea of prematurity. That's what we normally give. We use it in our center. Okay, but we still need to check to have some data on it, because few of them may not even maybe maybe we check some of our documents before we started using caffeine. Whether when we're using aminophylline, maybe we need to have some local data and find out how difference would be, whether the children that use caffeine are better off. So also we need to check some other studies. So it's still not in our experience. We don't have experience with that. Is any other question? Okay.
Yes, there's question on. My questions are, somebody says the questions are, did not get the dose of surfactants therapy, okay, and what's the maximum dosage? What are some of the early?
The slides was 4.
What are some? Okay.
4.
Go ahead.
4 could be between 1, 2, or 4. However, I don't know whether it's referring to dose in terms of per dose. Per dose depends on the product. Okay, the one we use is 5 ml per kg, which is blessed surfactant. But from the literatures, there are some that you can be given like 3 ml per kg, some 4 ml per kg, some 2.5 ml per kg. It depends on the make. So I don't know whether it's referring to per dose or is the number of doses. Number of doses between 1 to 4, and if it's per one episode, per one for giving, then talk about depends on the product.
Okay. Thank you, Dr. Kefas. Which type of shock is most commonly seen as a cause of respiratory distress in newborn? That's from Dr. Anya. Which type of shock is commonly seen as a cause of respiratory distress in newborns?
Well, it will depends. If you say it's commonly, it can be septic shock, because most of them, there's only very few that can come with features, maybe like bleeding or maybe those that bled, and diarrhea, vomiting, all those ones, they are not. So hypovolemia is not as common as that. Then some that has cardiac problem can have cardiogenic shock.
Okay. Ahmed Achanya is reasonably hard. Ahmed Achanya, are you ready? Please go ahead with your question. Ahmed Achanya, unmute your mic and talk. Ahmed Achanya, unmute your mic and talk. Dr. Suberi is also on panel to answer questions, and Dr. Peter is also available to answer any questions you may have. Ahmed Achanya, are you ready to talk? Just unmute your mic and talk. Benga Ogunjobi, I can see your hands are raised as well. I want to allow you to talk as well since Ahmed Achanya is not ready. Benga Ogunjobi. Or maybe they raised their hands by mistake. Benga Ogunjobi. Questions? Okay, maybe they raised their hands by mistake. Okay, so another person asks, thank you, Dr. Kefas and Dr. Peter, for the presentation. Can maternal absorption of dangerous gaseous compounds lead to respiratory distress syndrome? Can maternal absorption of dangerous gaseous compounds lead to respiratory distress syndrome?
It depends on the gas in question. It depends on the gas in question. So, but remember we talk about some ominous protective measures when the mother is maybe on narcotics or maybe drug abuse, even though we said it has its own ill, but it's among the protective measures in which some of the children born to this woman that are drug addicts. Okay, but Dr. Peter, I have one or two things to say.
Okay, so maternal exposure to dangerous gases. This dangerous in the sense of danger will ultimately predispose the mother to preterm labor, and preterm labor could lead to preterm delivery. And when the babies are delivered preterm before the maturation of the respiratory system, before the point of the age where surfactant is produced, they are at risk of respiratory distress syndrome. So the link between those dangerous gases will link via causing maternal ill health, making the mother have preterm labor, preterm contractions, delivering the babies earlier, and then being born earlier will now cause the risk of respiratory distress syndrome.
Okay, so I'll read some questions and answers that have already been answered. Dr. Subera has been answering some questions in the Q&A box. Somebody said, can you expatiate on the relationship between antenatal steroid use and respiratory distress syndrome? The answer is antenatal steroids is inappropriate dose, helps to reduce the occurrence of respiratory distress syndrome. And that's what has already been answered. Somebody said, what is cold stress? What is cold stress? And how is maternal hypertension a decreasing risk factor for RDS? And if a preterm blood transfusion, I think I've answered that. Cold stress is basically the exposure of the body of the baby to cold and subsequently begin to affect the body. Okay, and then somebody said, what's the side effects of betamethasone or dexamethasone given as a prophylaxis before delivery? The answer already reported here is no serious side effects have been reported. A few studies have reported reduction in fetal body movement and heart rate variation, but there is no serious side effects that have been reported from the use of pre-term or pre-delivery betamethasone and dexamethasone. Okay, somebody said, can respiratory distress syndrome occur after 6 hours? And it has already been answered. They said yes, of course. It usually occurs within 24 hours of life. Onset depends on the amount of surfactant in a neonate. Some of the questions have been answered here. I just need to read them out for the benefit of other people who may not have read them. Okay. We've answered quite a number of these. Okay, can you give a guide on how to make improvised CPAP? Can you give a guide on how to make improvised CPAP? Somebody is asking. Somebody's asking if you can give a guide on how to make improvised CPAP. Okay, so we're in a resource poor environment, perhaps.
Okay. Maybe it's very important. It's a very important question because in a resource poor country, it's very important that every center where you have a labor room, you have deliveries, and sometimes you may even have premature delivery. Sometimes you may not be able to prevent it. They may just come head-on perineum. So when that one occurs, definitely, so arming ourselves with what is supposed to be, just like radiant warmer and other things like the oxygen and other things. Then one of the things, especially in the premature, where if they are presenting with if they have the likelihood of having an RDS, especially those the premature that are less than 34 weeks, and you expect that RDS could come in. So the only thing for you is CPAP is very important, especially at the beginning. So remember in our unit, before even in the labor room, before the baby even come out, we have to even prepare and and keep it in waiting, so that if the baby is manifesting with features of that, the earlier you start CPAP, the better. Studies have shown that it actually helps the outcome. It reduces the frequency of these babies eventually needing mechanical ventilation. So going back to the question, I wish something like diagram that could be available that we could have shown so that to see what is being done. But the simple way we can do it, while I have this water here, can get this kind of water like Ever water, and as simple as this, and make sure you can now perforate the top. Okay, then the oxygen prong, I wish I could have carried this, but the oxygen prong could be, maybe we'll, I don't know whether we'll send the diagram maybe through the emails or so, but the oxygen prong, they have to cut one of it, then they have to cut one of the limbs, then tie it, then connect one of the one to the nose of the child, straight to another extension, be like giving set into the water. Okay, from the top of the water, just about 5 cm. It could be actually be more, but at least you can start with 5 cm. The length, that's give you the pressure of at least 5 centimeters of water. Then you connect the other limb to the oxygen source. Okay, you can start at left as maybe like 5 liters per minute. So with that, we normally do it, we test run it even before the baby even comes. But in case if the baby is already out, that's a simple way of doing it. So local things around, giving set, nasal prong, and this to be able to produce bubbles CPAP easily. Thank you.
Okay, I hope that helps. But it's quite important that if you are practicing, you should try and get a CPAP machine because it's quite important. Yes, the improvised CPAP also does work and gives quite good results. So somebody says, in the use of ABG score, must one use all of the components of the score, or one can only use 1 or 2 of it? This is because in most centers, the use of SpO2 via pulse oximeter might be the only available instrument. Did you get a question by Dr. Lawal? Must you use all the components of ABG score? Or can you just use one of it because SpO2 might be the only available instrument in most centers?
The ABG score is a special pressure of oxygen, which is different from the cutaneous check.
So as a rule of the thumb, there is this simple rule of 4, 5, 6, 7, 8, 9. So we look at the pressure of 40, 50, 60, correlating with oxygen saturation of 70, 80, 90. So oxygen saturation of 70 correlating with the pressure of 40 millimeters, 4.89. So if we have, this is a rough rule of the thumb, but it works. So in a situation where oxygen saturation is what we have, we can as well use that as a rough guide. Yeah.
Okay. And that question says, at what stage do you consider constant 100% oxygen saturation as not normal in the management of a neonate? At what stage do you consider constant 100% oxygen saturation as not normal in the management of a neonate?
Okay, so oxygen we give commonly. Oxygen is a drug, and if a child on his own is saturating in room air at 100, fine. But by the time we have oxygen, supplemental oxygen above 92, 93, it's fair. So giving oxygen for so long, one, oxygen is a pulmonary vasodilator. So at what stage is it not normal? One, for babies that have cardiac shunt lesions, because there will be flooding of the pulmonary vasculature. Two, if it is given for so long, bronchopulmonary dysplasia is a risk that contains. So it is a problem that creates its own like positive feedback. First of all, it will damage the lungs. 2, the child will need to be on it. So it's dangerous. 3, situations like air leak syndromes, you do not want it because giving it for so long, you could trigger rupture of alveoli and cause air leak syndromes. So if a child can saturate at this level on his own, fine, but not because you are giving oxygen to keep the child saturating at that level. Yes.
Okay, thank you very much, Charles. Thank you very much. I think this is quite explanatory. Somebody says, is oxygen concentrator good enough to resuscitate an asphyxiated baby after clearing the airway? Dr. Dennis, is oxygen concentrator good enough? You don't have the oxygen cylinder, you just have the oxygen concentrator to resuscitate an asphyxiated newborn after clearing the airway.
Yes. Yes, it's being used in some centers. That's what they use. They don't have in some centers. That's what they use, and it's safe.
Okay, so I think a lot of things we can improvise in our centers to make it work, but as soon as you can, try and get a specialist input, try and get specialist referral. If you have some of those things, call in early, especially if you're in Abuja region, so that our neonatal team can come with the mobile incubator to your center even before the baby is born, ready to resuscitate, and then take to the neonatal in ICU. Okay, so some of those things you should prepare for them ahead of time. Okay. Somebody says it's a macrosomic baby, not infant of diabetic mother, but just macrosomic at risk for respiratory distress.
No, what's other risk factors?
No. Except there are other risk factors.
Okay, thank you very much. Then somebody said, going from the preliminary reports we presented, the highest incidence of respiratory distress was noted in normal birth weight neonates. What factors were noted to be contributory? Can we reduce this prevalence?
Okay, so if we see that by the time we add the birth weight stratification, we add 13. So really, it was not highest in the normal weight, because low birth weight, very low birth weight, extreme low birth weight, all make up low birth weight, make up abnormal weights. So we only did further stratification of the preterm class. So, and if you find it, it was actually higher in the very low birth weight class of those that were low birth weight. Now, coming to finding it in normal weight babies, remember, if we go to our etiology, because that would answer the question, we had babies with 7 babies with cardiac lesions, 7 with transient tachypnea. These were all not preterm. All the babies with hypoxic ischemic encephalopathy were not preterms. All the babies with meconium aspiration were not preterms. Now, the respiratory distress syndrome that even occurred commonly in preterms, we even still had 10 babies who were infants of diabetic mothers who are affected, who also have surfactant affectation, because the maternal hyperglycemia triggers a fetal hyperinsulinemia and then distorts this myelin-sphingomyelin ratio of surfactant. So it is an interesting finding. It is not absolute. It's not an absolute truth that it was higher in the normal weight babies, because that difference was because we stratified the ages of those that were lower weight. But yes, we had this number in those that were term neonates.
Okay. Thank you very much. I will be looking forward to the publication of the paper. I have noticed that most of our preterm gets missed. I don't know. Eventually most of our preterm eventually have increasing episodes of apnea. Is this a possible side effect of the therapy, or is it related to other issues?
Okay.
I don't quite understand the question, but do you understand the question?
Yes. Okay. Well, it now depends on, most of the time, these babies, as we said earlier on, that can repeat these doses, but most of the time we find out that most of the parents may not be able to afford maybe to have 2, 3, or 4 doses. So maybe if you have only 1 dose and eventually the parents could not maybe provide, let me put it that way, then sometimes it could be. But of course, we know that there's no therapy that doesn't have a side effect. Of course, we mentioned some of the side effects of the therapy, but of course, most of the time they lack to add more doses. So we need more doses in order to make there are some children that sometimes we give here maybe 3 or 4 doses before eventually they are discharged and they are fine.
Okay, so it's not our own observation actually that most babies that get minimally invasive surfactant therapy will have increasing episodes of apnea. Now, if we look at it, we are even going minimally invasive. We are using a very narrow, small tracheal catheter, which is actually less invasive. Now, these babies primarily have respiratory distress syndrome, which the surfactant is supposed to help and actually helps, gets the baby out of respiratory distress as fast as possible. However, knowing that they have various stratifications of gestational age. Now, imagine a baby who is 27 weeks, 28 weeks gestation, who will need multiple therapies of surfactant. Now, apnea on its own, if you can see the screen, when we definition of terms for respiratory distress, say abnormal respiration. Abnormal respiration can be tachypnea, can be bradypnea, can be apnea. So that child still having apnea still has respiratory distress. So it's not yet out of respiratory distress. So that is it. So it's not our finding, they improve with surfactant therapy and not as if surfactant is a. So possible side effects of surfactant therapy could be, if it's administered by somebody who's not well skilled, damage to the upper airways from the use of the laryngoscope. That is not common because you have to be well skilled before you give it. We do it carefully. Also, in very rare events, as the side effect that could be said as side effect is pulmonary hemorrhage, and we don't have that as one of our findings. So apnea is still an entity. So the child still having apnea still has respiratory distress, still needs more surfactant therapy. So when persistent pulmonary hypertension sets in, what other thing can be done? Is there specific management for persistent pulmonary hypertension? And if yes, when do you start seeing improvement? So we said persistent pulmonary hypertension, otherwise the new term for persistent circulation. The problem is the pressure in the right chamber of the heart is still very high. These children observe on oxygen support. So we commonly place them on continuous positive airway pressure. Now, if that fails, not having improvement persistently, because you realize that they have very fast respiratory rate and desaturation, so which improves marginally with gene therapy. The next step is to go to mechanical ventilation. Now, if they fail, commonly you want timeline, 2 to 3 days, there should be significant improvement on CPAP. However, you must understand the definition of pulmonary hypertension, because the degree of the pulmonary hypertension is going to determine the severity of the pathology. So now, formally, just a brief, the 4th World Symposium of Pulmonary Hypertension held in Nice, France, 2013, defined pulmonary hypertension as mean arterial pressure greater than 25 millimeters of mercury, measured by right heart catheterization. However, it was updated in 2018, now brought down to a value of greater than 20 millimeters of mercury. Now, but we use echo because we use some complex equations to calculate. Now, the child who has pulmonary pressure, mean arterial pressure of 21 millimeters of mercury, will be less sick compared with the one who has 28 millimeters of mercury. So you expect that improvement will be faster in the child that has a lower pulmonary pressure. But persistence of symptoms 3-4 days for moderate pulmonary hypertension, we will want to step up to mechanical ventilation. And the child not showing any improvement, the next step is to give surfactant therapy, because surfactant is indicated in unresponsive pulmonary hypertension. We pray it resolves at that point, but if not, then you go to extracorporeal membrane oxygenation. So those are the layers, but commonly we've done well, even mild and even moderate persistent pulmonary hypertension on CPAP in our center.
Okay, great. Somebody asked, what do you do in the case of when the parents of the child with natal distress is financially handicapped?
It's okay. It's okay. So the fact is, healthcare is expensive, but neonatal care is even more intensive. And as such, it is basic that this would, well, they could get financially handicapped parents who walk through HMOs for support. Financially handicapped parents could get loan, could get treatment, but the truth is, wherever neonatal care is going to be given, it will cost some money. We have had to refer like 1 or 2 one unit in particular because of this. However, when we do what we do here and get good results, I think from us, and I think that should pay, because the life of the baby it should be more valuable than the cash. That's what I think. But our boss can throw more light on the economics of health.
I can't throw more light on anything. So definitely you are correct. Healthcare costs a lot of money, and it's unfortunately private healthcare is not funded. So what we have resort to doing is we also get sponsors. Sometimes the hospital sponsors to an extent. Sometimes other patients sponsor. Sometimes relatives sponsor. You know, it can be quite a difficult challenge to manage when you don't have money, because as you all know, nothing is made in Nigeria. So everything has to be imported down to Nassau Prong. So it's quite costly to manage a unit and to keep that management ongoing. Arterial blood gases is extremely costly. So some of these things, and that is the reason for insurance to help with some of these things. By and large, we've been able to get by with some assistance from individuals and from well-meaning Nigerians to provide healthcare. Okay, so that's what we have done so far. All right. At what stage of labor, I'll take this last question from Dr. KK, consultant gynecologist. At what stage of labor in a preterm delivery should the neonatal team in the labor ward be in the labor ward, knowing that second stage can last up to 1 to 2 hours? It's asking a practical question. When should the neonatal team get to the labor ward, knowing that second stage can last up to 1 to 2 hours? Well, I will try and answer first before the pediatricians answer. What I would say is that the neonatal team consists of the gynecologist as well. It consists of every doctor and every nurse. And that is one of the reasons why we are holding this lecture. Everybody should be able to do a lot of the basics, enough to take care of a unit until the neonatal team arrives. So the gynecologist, the anesthesiologist, the midwife, the nurses in care, if you don't know how to take care of a neonate that is not breathing, you probably should not be delivering a baby in the first place. So you deliver the baby, start what you need to do, and not as if every baby, the pediatricians must be seated in the labor room. Then we have to now have a pediatric, we probably will now have to have pediatric teams in all labor rooms in Nigeria. So practically for most other smaller centers, it may be difficult to have pediatricians in all the rooms. So for bigger centers, yes, the pediatricians can come in before the preterm labor and be ready for that. But I would like to say that everybody should be skilled in learning how to resuscitate so that the pediatric team doesn't have to turn to a delivery team. Dr. Peter, over to you.
Okay, thank you. That's very, very clear, and that is it. Although in our own center, all preterm deliveries should be seen and is seen by the consultant pediatrician. So for us in our center, notify us, will be on ground. However, our boss has answered as it is. So the basic thing there is neonatal resuscitation, which is a skill that all doctors should have. And that's why it's part of our annual training, our pediatric symposium, where we train doctors on neonatal resuscitation. So the general practitioner who is in the labor ward should know how to handle it. So a woman in preterm labor, doctors must be on alert. Equipment must be set to handle it. But in a center, a big center like ours, let the consultant pediatrician be aware, he will be around.
Yeah, so for bigger centers, definitely will be on ground. But if you're a smaller center, please learn how to. If you are in Abuja or nearby and you have questions, you can, even if you're not in Abuja, send the questions via email. You will see it on your screen. Send the questions via email so that we can assist in answering some of your questions. And then if you need any assistance and you're in Abuja on the environs, you can pop in, we can show you. And when the lockdown and hopefully all this COVID thing ends, one of the things that we do is that Abuja Pediatric Symposium where we teach. I want to thank the pediatric team of Limi Children's Hospital for helping us with this beautiful topic, for helping us to learn about respiratory distress in neonates, how to diagnose, and they've talked on the different etiologies that could happen. So this was brought by Cardiocare Hospital and by the Children's Hospital, Limi Children's Hospital. Cardiocare is involved in cath lab, cardiology, endo, neurology, hepatology. That's our cath lab, and we do quite a lot of amazing things without open surgery. And then the pediatric team also does quite a lot. Pediatric cardiology, endocrinology, neonatology also happens with the pediatric team. This is our transport incubator, which we move to the labor room so that as soon as the baby comes out, resuscitation starts immediately and the baby can be in an incubator within a short time, immediately after resuscitation. Okay, and this is one of the CPAP machines, this is an air oxygen mixer right there in the Limi Children's Hospital, one of our machines in the NICU. And then, that's the infant flow neonatal CPAP driver. This is the Limi Children's Hospital. This is what it looks like. It's in Wuse 2, easy to locate. And every Friday, so from this week, next week, Friday, we will not be holding any webinar. We'll be taking a short break and we'll resume on the 19th of February, where we'll be taking an industry-sponsored presentation. You will get via email, likely on pulmonary embolism and embolic diseases, what causes sudden death. And of course, pulmonary embolism has been heavily implicated in management of COVID patients, and protocols have come out for use of anticoagulants in COVID. So we'll be talking about that on the 19th. So next week, we'll be taking a break, put ourselves together. We have been doing this steadily for about 7 weeks now. So we need to take a short break. Next week, we'll not have it. So upper week, we'll be back. So next week, we'll have it only for the Limi Hospital doctors, as usual, because we always have ours. And then for everybody, we'll have that from the upper week. And then we'll come in with a bang, and it will be a quite big one. You'll see the adverts on WhatsApp, on Facebook, on Instagram, on YouTube. Now, if you go back to, if you go to YouTube later on after this, you should be able to rewatch this presentation about a couple of days, 2-3 days time. We'll upload it there. But if anybody still signs up with the same link, they can rewatch the presentation on neonatal resuscitation, neonatal respiratory distress. So thank you very much. Are there any final comments for the pediatric team? Any final comments, Dr. Suberu? Dr. Peter, any final comments? So thank you very much. And thank you for thanking us. I think that is Taiwo Orimoloi. Thank you so much for thanking us, and I'm happy that you are all benefiting from this. Our hope is that Nigerian healthcare gets better, and it gets better through more better equipped doctors. Doctors are equipped. So we have learned in medical school, but now we are in the real field. How do we tackle it in our individual areas? So that's what we are hoping to achieve. And where you need assistance, the specialty hospitals that are support hospitals, Limi Children's Hospital, Cardiocare, and even Limi Multi-Specialty Hospital provide an ecosystem that can help to assist in the care of your patients. Dr. Peter, do you have anything? Dr. Peter is also the MD of the Children's Hospital. Do you have anything to final say?
All right, so we want to thank our esteemed audience for joining up with us. We are ever ready, we are ever active, both with patient management, following up of our patients. The hospital works 24 hours, and we just want to make sure that families are happy in Abuja, in Nigeria, and worldwide. So what we do, we try to make sure that we give quality healthcare to the babies that come, so that those babies get well, the families are happy. So happy family through great healthcare is our focus in this hospital. And you will actually be impressed to receive the best when you have the reason to join us. Thank you.
All right, thank you all. God bless you. We'll end the webinar now. Have a lovely weekend.